I'm a nurse working worked both in methadone clinics. When I was going through my PhD program, I worked in methadone clinics, and then also be a float nurse in the acute care settings, in the inpatient units. And it wasn't uncommon that a patient of mine that I was taking care of in the methadone clinic, I knew them, I knew their pain, I knew their struggles, I knew their families. They'd come into the hospital with some sort of painful condition, and I would find that their pain would be entirely undermanaged. People would call them addicts and call them clock watchers and just not be attuned to the fact that these patients had real pain as well. So I come to this field from a nursing perspective of looking at the patient as a whole with respect to both their pain and their addiction backgrounds. So we're talking today about translational research, and so I just wanted to give a little bit of an overview of what that is. Translational research has been defined as an interdisciplinary branch of the biomedical field supported by three main pillars, moving from benchside to bedside to community, which means work that's being done in the laboratories and looking at cells and molecules is translated to the bedside, translated to the human, and then the work that's being done with humans is translated to community-based research so that the work we're doing with individuals can actually help a greater part of the community. The efforts of translational research are directed toward converting basic and clinical research discoveries into new clinical and research tools, medications, and therapies. And this conversion step is important because it's often where a bottleneck occurs in terms of progress in healthcare provision. The people who are working in the labs don't always speak to the people who are taking care of patients, and the people taking care of patients don't always speak to the community providers. So the ability to have the scientists across these different spheres speak to one another will really have impact on the health of the population of this country. And I believe that translational research is really the essence of nursing research. Nurses have always been busy translating bioscience to the human health experience. We're the ones that are taking care of the patients and interpreting and utilizing what's learned in the lab to taking care of the patients. So when people talk translational research, I've always thought nursing research. We have our National Institute of Nursing Research, which is a component and institute of the National Institutes of Health. So nursing has its own institute within the National Institutes of Health. And there we are working to build a scientific foundation for clinical practice. So again, taking these basic science findings and bringing them into the clinical setting. And the research that's done in this institute provides the evidence to support nursing practices. So today I'm going to be covering two types of translational research. The first from bench to bedside, so what we're learning in the laboratory and with animals and how do we bring that to the humans, to our human patients. And I'll be using the exemplar of opioid-induced hyperalgesia. And then I'll be talking a little bit about translational research moving from the bedside, moving from the patient to the community. And for that I'll talk a little bit about the new CDC guidelines, relatively new CDC guidelines that came out about prescribing opioids for chronic pain. And then I'll finish up talking just a little bit about the limitations of extrapolating from the preclinical, the animal and basic sciences, to the clinical in models of chronic disease, because I'll be talking about how both addiction, substance use disorders, and pain are chronic diseases, chronic illnesses. So to begin with, and moving from the bench or the laboratory to the bedside, opioid-induced hyperalgesia. Opioid-induced hyperalgesia, if I define it, is an increased sensitivity to pain resulting from opioid administration, such that pain-free animal models, if you give them opioids repeatedly, they have significantly decreased thresholds to pain, which is kind of counterintuitive. You'd think if you were giving animals or humans opioids, strong pain medications, that they'd be able to tolerate pain better. But what we've seen is over time that they actually become more sensitive to pain. Opioid-induced hyperalgesia is characterized by increase in pain intensity over time, so that the longer the animal or the human is on opioids, the more sensitive they become to pain. That the spreading of the pain goes beyond the local pain site, so if it was an incision or an injury that initiated the pain, with opioid-induced hyperalgesia, the sensitivity to pain goes beyond that area of injury, tissue injury or wound. And this increasing sensitivity to pain is to painful external stimuli. So anything that would be felt as normally maybe a little bit painful becomes extremely painful for the patient with opioid-induced hyperalgesia. There's the theoretical underpinning to describe opioid-induced hyperalgesia is that it's actually an imponent process. So as you can see in this graph, if we start out with a normal patient's pain tolerance and we give an opioid, initially you'll see opioid-induced analgesia. So in other words, the patient becomes desensitized to pain. But over time, as opioids continue to be administered, the opponent process of opioid-induced hyperalgesia or sensitization comes in. And over time, you can see that that becomes the stronger of the forces, and that patients' pain tolerance actually goes below baseline. So it's an opponent process. And it's believed that this opponent process is functional, such that somebody on opioids for a long period of time, you still need to be able to feel pain. If you stub your toe or break your leg, you still need to be able to feel pain. So the idea is that the neurophysiology of your brain and your spinal cord, the central nervous system, kicks in to ensure that even though you're on opioids, you can still experience pain. So it's believed there's a functional reason for the development of opioid-induced hyperalgesia. So this is a busy slide, and it's basically just an overview of what we've learned about opioid-induced hyperalgesia from the animal model, the preclinical model. And I'll just go through these very quickly because then I'm going to talk a little bit about how we look for these in humans. But essentially in the animals, we know that if you give them opioids on a regular basis, we see a reduction in their pain tolerance, their pain threshold. I mentioned that a minute ago. That we see that across different types of painful or nociceptive stimuli. So it can be thermal, cold, heat, chemical, electrical. Doesn't matter which type of painful stimuli we're administering, but you can still see this opioid-induced hyperalgesia occurring. It's demonstrated across the class or type of opioid. So whether it's heroin or fentanyl or morphine, we can still see this hyperalgesic phenomenon arise. Demonstrated across the route of administration. So whether we're giving it intravenously or orally or subcutaneously, you'll still see the same occurrence. It's also dose dependent, so that the more that the patient or the animal receives, the higher the cumulative dose or the cumulative exposure to the opioids, the more that the higher that the amount that the individual receives, the greater the opioid-induced hyperalgesia. It increases hyperalgesia or pain sensitivity around the wound, so that surgical patients, their incision site, if they have opioid-induced hyperalgesia, their wound is more tender, the incision's more tender. The resolution of opioid-induced hyperalgesia is similar to the time course of its development. So in some patients where opioid-induced hyperalgesia comes on relatively slowly, it'll offset relatively slowly as well. If it comes on rapidly, it'll be a more rapid offset. The larger the response of opioid-induced hyperalgesia is also related to longer lasting. So patients that have a large opioid-induced hyperalgesic response will also have a longer lasting response. It intensifies with antagonist-precipitated withdrawal or worsens with repeated withdrawal episodes, so that the more often the animal gets the opioid, goes through withdrawal, gets the opioid, goes through withdrawal, the greater intensity of the hyperalgesia. It's been shown to be more robust in female animals, so that women, we know they have differences not only in their pain perception, but in their opioid responses, and so opioid-induced hyperalgesia appears to be more robust in females. And it appears to also share some of the mechanisms underlying the development of neuropathic pain. And neuropathic pain is different from nociceptive pain, which is, nociceptive pain is if you stub your toe or you break your leg. Neuropathic pain arises from actual changes in the nervous system, which makes people feel pain even though there's no painful stimuli there. And so some of the molecular mechanisms, and I'll have a slide on this in a minute, that cause opioid-induced hyperalgesia, we believe cause opioid-induced hyperalgesia, are some of the same mechanisms which underlie the development of neuropathic pain. So we've learned a lot in animals, but the question is bringing it over to the humans. Now this is another animal study looking at opioid-induced hyperalgesia in a preclinical animal model. And this is basically a graph that's kind of emphasizing what I just said in a lot of words. That in animals, to provide opioids, sometimes we put a pellet under their skin so that they get a constant exposure to opioids. And what this graph is showing us, the withdrawal threshold, is the time at which an animal will remove his tail from hot water. So that's kind of their withdrawal threshold. And you can see in animals, the control animals received a placebo pellet. They received no opioid. The animals in blue, the morphine, they received a morphine pellet. And the animals in green not only received a morphine pellet, but also received that Narcan, that antagonist, so it precipitated withdrawal. And you can see that after the pellet has been removed, with the control animals who received nothing, there's really no change in there, how long they keep their tail in the hot water. With those that received morphine, you can see a significant decrease in the number of seconds that they're able to keep their tail in the hot water. And for those animals that had not only morphine, but we put them into withdrawal, you can see an even more significant difference in how long they were able to keep their tail in the water. So some good animal-based data to provide evidence of this phenomenon occurring. So these are some of the theorized mechanisms underlying opioid-induced hyperalgesia, and this is just kind of a schematic of the nervous system as well as the immune system. I'm not sure if I have a... There we go. Okay. So consider this your peripheral neuron. This is where the pain stimulation would initially come in. So that's when you're first feeling it. That's out in the periphery, out in your hand or your leg, where you're going to feel the pain coming in. It then travels to the central nervous system. This is the spinal cord. Okay. And from the spinal cord, it travels up to the brain, where we can actually perceive pain. And at each of these points, there's theorized mechanisms by which opioids cause the pain. Cause opioid-induced hyperalgesia. Opioids, there are opioid receptors in your peripheral nerves, and it's been demonstrated by giving opioids over a period of time that you can see an increase in what are called pro-inflammatory chemicals or pro-inflammatory cytokines. So that there's substance P and other chemicals that are released here in the peripheral neuron, which make pain feel more painful. Also, within the spinal cord, there are some changes that when opioid receptors bind to opioids bind to certain receptors in the spinal cord, that it actually increases the release of certain neurotransmitters or neuromodules known as excitatory amino acids. And excitatory amino acids, NMDA is one of the types of excitatory amino acids. As it sounds like, it's an excitatory neuromodulator, so it actually tunes up. It's more excitable for painful stimuli coming up. And then also with the brain, when pain gets first to the brain, it goes to the brainstem, kind of the primitive part of the brain. And there's some evidence that by binding to certain opioid receptors in the brainstem, that there's actually chemicals that head back down the spinal cord and intensify the feelings of pain. So there's several mechanisms by which within the nervous system, both peripheral and central nervous system, that might explain this development of opioid-induced hyperalgesia. And I've also put a little immune cell in here, okay? Immune cells, like white blood cells, these are immune cells that line the central nervous system that are within the spinal cord. They form the blood-brain barrier. And there's evidence, and we've always known that immune cells have opioid receptors on them, and we weren't quite sure why. When opioids bind to these immune cells actually start to produce and release certain types of pro-inflammatory cytokines. So it may be that the immune cells, by releasing these pro-inflammatory, these excitatory sorts of chemicals, tune up the perception of pain both in the peripheral nerve and the central nervous system. So in addition to the nervous system being involved, it also appears that our immune system may be contributing to the development of opioid-induced hyperalgesia as well. And so this is just going through each of those mechanisms in greater detail. There's the peripheral nerve with the painful stimulation coming in, increased responsiveness to neurotransmitters. There's the excitatory changes that happen within the central nervous system. There are these other pronociceptive spinal neuropeptides, other chemicals within the nervous system that kind of tune up the feelings of pain. The descending facilitation, meaning signals come from the brainstem back on down the spinal cord to increase the perception of pain. And then those changes that occur within the immune system to increase the release of neuroinflammatory, pronociceptive, pro-pain sorts of processes. But now let's move to the clinical model. You know, how important is this a phenomenon of opioid-induced hyperalgesia in patients? And you can see from all of these papers that have recently come out that there's question in the clinical literature. Opioid-induced hyperalgesia, is it clinically relevant for the treatment of pain patients? Prevention of opioid-induced hyperalgesia in surgical patients, does it really matter? Do opioids induce hyperalgesia in humans? An evidence-based structured review. So there's still questioning in the literature, in the scientific literature, about how important is this opioid-induced hyperalgesia in the human model, and especially in humans who are experiencing pain. So I'm going to talk about what we know about opioid-induced hyperalgesia in clinical populations and in humans. There's really only three populations that have been studied to look at opioid-induced hyperalgesia, and those are patients who have a substance use disorder, an opioid use disorder, who are on medication-assisted therapy. And by medication-assisted therapy, I'm talking about methadone, a full opioid agonist, and buprenorphine, which is a partial opioid agonist. And these are medications that we use to help treat patients who have an opioid use disorder. They also have looked at patients who are administered opioids during the perioperative or the surgical period. Those of you who work in surgery or are healthcare professionals know that when you undergo surgery, you're usually given large doses of opioids. So we've looked at opioid-induced hyperalgesia in patients who are undergoing surgery. And then finally, there are some studies looking at healthy volunteers who are administered opioids and then undergo pain testing. So these are kind of the three places where we have looked at opioid-induced hyperalgesia. So translating what we know in the animal model to the human. This is the research that we have out there. This is some early work that we did looking at cold pressor, CP, pain tolerance in current and former opioid and cocaine abusers, And CP, the cold pressor pain tolerance, cold pressor is basically a glorified bucket of ice water, but it's a well-established assay for measuring people's pain. And so we had them put their hand in the ice water, and they tell us when the when the cold first becomes painful, and that's pain threshold, and then there comes a point where they pull their hand out of the water because they can't tolerate the pain anymore, and that's called pain tolerance. And so what was measured here on the the y-axis are the number of seconds that the patient can keep their hand in the cold water. You'll notice, first of all, that the patients who are no longer abusing opioids or cocaine are much better able to tolerate the pain for a longer period of time. So there's something about becoming clean or getting into recovery that makes it easier for patients to tolerate pain. When you look at the patients that are still using opioids or cocaine, their ability to tolerate the pain is much lower. And of that group, the patients that are least able to tolerate pain are people who are opioid abusers. The majority of these opioid abusers were people on methadone, and on big doses of methadone, 70 milligrams of methadone a day, and yet they were the least able to tolerate the simple cold pressor test. And if you or I had 70 milligrams of methadone, we might be able to be hit by a bus and not really feel it. That's a lot of opioid. And yet here were these patients taking that large amount of opioid who were much less tolerant of pain on this very simple pain assay. And these are some data to kind of support or look at that phenomenon a little bit better. This bottom graph here shows the same sort of thing with methadone-maintained patients versus control patients. So these were normal, healthy controls matched on age, gender, and ethnicity. And again, you can see that the people on methadone tolerated the bath about half as long as control patients, as normal, healthy patients. And these are some data to show that patients on methadone, that one type of medication-assisted treatment, compared to patients on buprenorphine, the other medication-assisted treatment, both groups are much less tolerant than, again, healthy controls, the controls who are matched on ethnicity, gender, and age. So regardless if you're on methadone or buprenorphine, either of those medications to treat opioid use disorder, still much less tolerant of pain. Now, what was interesting to me is that this is not a new observation in humans. These are some quotes from some relatively early literature in the medical field. At such times, I have certainly felt it a great responsibility to say that pain, which I know is an evil, is less injurious than morphia. And morphia was the name that used back in the 1800s to describe opioid addiction, substance use disorder, which may be an evil. Here, experience is needed. Does morphia tend to encourage the very pain it pretends to relieve? Charles Carter, in the Journal of Inebriety, I'm not sure how to say that, he's also affected by a hypersensitiveness to pain or a morbid intolerance of any kind of distress. He suffers. His suffering is actually great. To his astigmatic inner eye, it seems even greater than it is. So kind of some early descriptions of people who are abusing opioids or have a opioid use disorder feeling pain more intensely. We have looked a little bit about how long does this opioid-induced hyperalgesia last, and these are patients who were in methadone treatment who underwent a detoxification. So they, after being on methadone for a certain period of time, they were tapered down off of their methadone, and we looked at them 28 days later to see if their pain responses had improved. Latency is referring to threshold. Again, when does the cold first feel painful? Tolerance is how long could they keep their hand in the water, and then intensity is how greatly did they feel the pain was on a scale of 1 to 100. Was it a 0 pain or 100? And you can see that comparing baseline, the dark, to the 7 days to 28 days, that again, patients in the opioid addiction group were less tolerant than control patients, but that over the course of the 28 days, their pain did not necessarily improve. So this idea of opioid-induced hyperalgesia, if in fact it's opioid-induced, we didn't see changes happen when these patients came off of opioids. Now this only goes out 28 days. It may take longer to see those kinds of changes in these patients, but it suggests that the pain intolerance in patients who are on methadone or buprenorphine may not actually be opioid-induced. We call it opioid-induced hyperalgesia, and we see that in animals. But in humans, we know that patients, especially with this cold pressure test that I discussed, are either pain intolerant or pain tolerant. It's a bimodal distribution. So that people can be born such that they're pain intolerant and can only tolerate the ice bath for about, usually around 60 seconds. This graph shows a little bit higher. And then the other 2/3 of the population are much more pain tolerant and keep their hand in the bucket for up to 3 minutes or up to 5 minutes. So could it be that the people who we see in our methadone clinics are actually the people sitting at this part of the curve? Are opioid abusers hyperalgesic by nature? And that explains why when we bring them down off the opioids, we don't necessarily see an improvement in their pain. And, thinking about kind of this genetic predisposition to being already susceptible for feeling pain more intensely, going back to some of the animal literature, these are all different strains of different types of mice. So we can breed mice very easily and really keep them genetically similar within these different breeds of mice. And what we see here is that there's a type of mouse that, this inbred type of mouse, there's a lot of studies done on it. This is, the graph is looking at opioid-induced hyperalgesic responses by the strain of mouse. And you can see that this mouse here has a fairly robust opioid-induced hyperalgesic sort of response, especially compared to a mouse in this genetic strain, which really doesn't develop opioid-induced hyperalgesia to a great degree. But what's interesting is that this strain of mouse not only develops opioid-induced hyperalgesia relatively easily, but they also have a baseline poor pain tolerance. They are basically your intolerant, pain-intolerant species of mouse. They also have a very poor analgesic response, so that when you give them opioids, they don't get a lot of analgesia from it. And they also find opioids highly reinforcing. It's very easy to get them to become addicted, so to speak, to opioids. Not all strains of mice are like that. Some mice, you have to hide it in their food, and they really don't develop addictive sorts of behaviors that we see in animals. So it's interesting that these ideas of opioid response and pain response tend to kind of gather together around the strain of animal, speaking to a genetic predisposition. And so perhaps the people we see in methadone maintenance, people who develop an opioid use disorder, not only are at high risk, maybe they look like this type of a mouse, that they not only are at risk for developing opioid-induced hyperalgesia, but they are already pain sensitive, they are already relatively pain intolerant, they don't get a lot of analgesia when you give them an opioid, and they find opioids highly reinforcing, and therefore may end up in trouble abusing them and meeting diagnostic criteria for an opioid use disorder. And again, that may be why when we take the opioids away, they still look pain intolerant. What's difficult about trying to make this interpretation is that most of the data in humans that relates poor pain tolerance or opioid-induced hyperalgesia with opioid use are survey or correlational studies. So we're taking a group of people who are already on opioids or recovering from opioids and comparing them to controls. What's been difficult to do is to actually take a patient who's opioid naive and start giving them opioids to watch what happens with their pain. Now, clearly, we can't take healthy controls and do that. The IRB would have some difficulty with us doing something like that. So that it's difficult to really say it's opioid-induced. We can't necessarily infer a causal relationship because most of the data have been correlational. And I'm just going, I've just listed a bunch of the different studies that have been done comparing people on opioids to ex-opioid addicts to match controls with respect to their ability to, with respect to opioid-induced hyperalgesia. And you can see in the lines in pink here that we've compared ex-opioid addicts to matched controls. Ex-opioid addicts are less tolerant of pain than our matched controls. The blue lines are studies where they've compared people on opioids to people who are no longer on opioids. And again, you can see that relationship of people on opioids of being less tolerant of pain than ex-opioid addicts. And the yellow bars here, they're sort of yellow, are comparing people on opioids to matched controls. And again, you can see people on opioids are less tolerant of pain or have more opioid-induced hyperalgesia than the matched controls. Now, the green bars here actually show us a different relationship. And so they're showing that patients who are ex-opiate addicts are more tolerant of pain. They have less opioid-induced hyperalgesia than matched controls, and it could be related to differences amongst the different research laboratories. These three studies are all done in the same laboratory. So, you know, we can't say for sure that we can't, they're all cross-sectional, so we really can't say for sure exactly what's going on. But I think the overall pattern is that people on opioids are less tolerant of pain than people who are ex-opioid addicts, are less tolerant of pain than people who are matched controls. But again, it's all survey cross-sectional data. Now moving on from kind of the methadone population that I spoke about, there's the second human population where opioid-induced hyperalgesia has been looked at are people undergoing surgery, people who are receiving opioids intraoperatively and their development of opioid-induced hyperalgesia. And it's been demonstrated that people who receive more potent opioids during surgery and greater amounts of opioids during surgery, when they come out of surgery, they have significantly higher pain scores at rest. While they're lying there in bed, they report more pain than patients who have received less opioids during surgery or less potent opioids during surgery. This increased sensitivity to pain is most pronounced during the early postoperative period, and it persists for about the first day, the first 24 hours. Most reliably, we see it with high doses of remifentanil, a very potent opioid that's given intraoperatively. These patients use more postoperative, use more postoperative morphine afterwards. So when they are using their PCA pumps or when they're being administered postoperative medications, they use about 18 milligrams of morphine more during their postoperative stay. Significantly decreased pain thresholds. They have a larger area of wound hyperalgesia, and I spoke about that previously. Their incision hurts more than other patients who receive less opioids. And we don't see any difference in other opioid adverse events. So opioids can cause nausea and vomiting and constipation in some patients. We didn't see the patients who received more opioids intraoperatively having some of these other side effects. It seemed to be only on the pain responses where we saw these differences. And we also didn't see differences in pain scores with movement. So it was pain scores at rest where the amount of opioids that received intraoperatively had an effect. So it makes you question how much of postoperative pain that we're treating all the time post-surgery is actually due to the amount of opioids that they received intraoperatively. And this is just another slide kind of talking about that same phenomenon of increased pain after surgery. This is looking at analgesia in total IV anesthesia where they're giving either remifentanil, again, that very, very potent opioid, versus sufentanil for their analgesia. Sufentanil is another opioid, but not quite as potent as remifentanil. And you can see that their visual analog scale scores on a scale of 0 to 10, how intense is your pain, the patients that received the more potent opioid had much higher pain scores. Okay, and this was number of hours after they were post-extubation, after they were woken up from surgery. So the patients who received more potent opioids complained of more pain in those first hours after surgery. And again, as I've mentioned previously, their pain was increased with higher doses and longer intraoperative exposure to these opioids, and that increased opioid consumption, postoperative opioid need, taking postoperative opioids for the treatment of their postoperative pain, was greatest for people that received a cumulative fentanyl dose of greater than 50 micrograms per kilogram. So the more that they received intraoperatively, the more morphine they used postoperatively. Now, one of the questions around this whole issue of postoperative opioid-induced hyperalgesia is that there is hyperalgesia that occurs when people withdraw from opioids, and that's known as withdrawal hyperalgesia. In animal studies, and in fact, when we look at a mouse and decide whether or not it's going through withdrawal, their pain is one of the things we look at. You know, animals going through withdrawal are less tolerant of pain. They are more pain sensitive. So hyperalgesia has historically been a symptom or a sign of opiate withdrawal in animals. If you look at the DSM-5 criteria for opioid withdrawal, and DSM is the Diagnostic Statistical Manual. It's basically our Bible on mental illnesses, mental disorders, that has a diagnostic criteria for things like depression and schizophrenia. It also has the diagnostic criteria for substance use disorders. And part of the DSM-5 criteria for opioid withdrawal does speak somewhat to pain. They talk about muscle aches being part of the withdrawal syndrome. We know that withdrawal hyperalgesia is worse with bolus dosing, when you're giving large doses of opioids in a bolus. It's also greater when you give people Narcan or naloxone and induce withdrawal. For chronic pain patients, when they're going through withdrawal, we see increased severity at the site of injury. That increases as they're going through it. And therefore, opioid withdrawal could be suspected in both normal control and post-operative samples who are no longer receiving the opioids. So that previous slide that I showed you of people on remifentanil having more severe pain after coming out of surgery, as opposed to opioid-induced hyperalgesia, could we be seeing opioid withdrawal hyperalgesia, such that their opioid dose is suddenly coming down, and therefore what we're seeing is opioid withdrawal hyperalgesia. And that would be evident in increased pain scores, decreased pain threshold, increased wound or incisional hyperalgesia, and increased opioid consumption and need. And I bring this up because it kind of, again, gets to, we can see something clearly in animals, but it's a little more difficult to extrapolate that to the human model. So now moving on from the postoperative population to just normal healthy volunteers. And in these patients, or these normal healthy volunteers, different studies have given either remifentanil, fentanyl, or fentanyl boluses over a 90 to 100 minute infusion. So a single dose of an opioid in this study, in these first studies. And they looked at pain threshold, both for heat and cold severity, and they found that patients were hyperalgesic for 2 hours following the administration of that bolus of opioids. If we induce if we cause some sort of a wound or injury to the tissue, an electrical burn or topical capsaicin, you could also see increased pain sensitivity around that area for up to 7 hours. So a smaller study has looked at administering morphine subcutaneously twice a day and found that opioid-induced hyperalgesia, they became more sensitive to pain over the course of days. But again, is it truly opioid-induced hyperalgesia? All of these measures were done after the infusion or the administration of opioids had finished. So could it be that we're seeing withdrawal hyperalgesia? These are some studies that we did looking at normal healthy volunteers. These were 18-year-old college students who had basically never been opioid exposed. They may have had an opioid earlier in their life for a broken leg or something like that. So normal healthy volunteers, we gave them a single dose of either morphine intramuscularly, morphine IV, hydromorphone IV, and hydromorphone is a more potent opioid, or placebo. And once we'd given them the drug, we came back about 30 minutes later and put them into withdrawal. We gave them Narcan or naloxone. We precipitated withdrawal in those individuals. And you can see that after a single dose of opioid, their tolerance for the cold pressor test greatly decreased. This is 5 minutes after the administration of the naloxone. This is 15 minutes afterwards. And you can see that their tolerance for pain after a single dose of opioids and putting them into withdrawal, that we saw significant changes in their ability to tolerate the cold pressor test. And those differences were greatest for the patients receiving the most potent opioids. So again, inducing this idea of withdrawal hyperalgesia in normal healthy controls. Now we know less about, and it's unfortunate we know less about, the phenomenon of opioid-induced hyperalgesia in patients who have chronic non-malignant pain. We know that at this point in the United States, approximately 5 to 8 million patients are currently taking opioids on a daily basis for the management of chronic non-malignant pain, meaning pain that's not cancer pain, it's not terminal pain, but pain that they're living with on a daily basis. Unfortunately, there have been very few prospective studies of patients who started on opioids for their management of their pain and looked at how that might have changed prior to getting opioids and then looking at them after opioids. I've got a few studies to show you. In these few prospective studies, they either compared patients on higher doses of opioids to patients on lower doses of opioids, or they compared them to patients who don't have chronic pain and their response to opioids. And what's been shown, what little we know, is that as the opioid dose increases, as it gets greater than 100 milligrams of morphine equivalents per day, so does the opioid-induced hyperalgesia. And that high-grade tolerance, the fact that patients are tolerant to the opioids and you need more opioid to get the same analgesic effect, is more likely to occur with opioid-induced hyperalgesia. In fact, it appears that there's a negative correlation between opioid-induced hyperalgesia and the amount of analgesia that they're able to get. So the more opioid-induced hyperalgesia that they have, the less able the analgesic effects of the opioid will kick in. We see the opioid-induced hyperalgesia more likely to occur with neuropathic pain. So again, that type of pain that's related to changes in the nervous system, not a simple wound. And the question becomes, does the presence of chronic pain, is it responsible for any baseline hyperalgesia? We know that patients who have this type of neuropathic pain are already sometimes hyperalgesic to begin with. They're already extra pain sensitive with neuropathic pain. And so do the opioids that we're giving, do they really induce the hyperalgesia, or is it something about the fact that they come to the opioid exposure already somewhat hyperalgesic. We don't know. This is one of those small studies looking at patients who received opioids for chronic non-malignant pain. And I'll just point out one of the difficulties in doing this kind of study is that by the time most patients who have chronic non-malignant pain show up in a research setting, they've already been exposed to opioids. It's very rare now to find somebody with chronic non-malignant pain who hasn't already received an opioid. So here's a few patients. This is 6 patients that had chronic non-malignant pain. Excuse me, I keep doing that. This was their ability to tolerate the cold pressor pain test prior to receiving the opioids. And after receiving 1 month of 70 milligrams of morphine, you can see that their tolerance for pain decreased over time. So that there is some evidence that we've got perhaps some opioid-induced hyperalgesia occurring in this chronic pain sample. This is another study, a very small study, looking at patients' development of hyperalgesia following 4 weeks of hydromorphone therapy, another opioid, and you can see that patients, these are the control subjects, so there was no change in their pain tolerance over time. But in the patients, over time, 4 weeks later, you did see that their BAS scores, again, a score of 0 to 100, with 100 being bad pain, had significantly increased after 4 weeks of being on hydromorphone. And this is another of the few studies out there looking at the painfulness of a standard lidocaine injection and showing that both their pain, their pain, the unpleasantness of the pain, and their pain behaviors, or how painful did they act, increased depending on what dose of opioids they were on. So the higher the dose of opioids, the more pain they complained of, the more unpleasant the pain was rated, and the more pain behaviors that we saw in those patients. And this is a standard lidocaine injection. These were patients that were undergoing the spinal tap, and so they were given a little bit of lidocaine with a little teeny needle to numb the area. And for patients who were on greater doses of opioids, they had more pain with that little lidocaine injection, and it was dose dependent. And this final study shows us a little bit more about how there may be an interplay between pain sensitivity and predisposition to becoming, to having an opioid use disorder, or to having a substance use disorder. This SOAP score is a screener for opioid assessment for pain patients. So it's essentially a screening tool to determine, is this chronic pain patient at risk for developing an opioid use disorder? And what we see is that patients that score high on this predictor, or this screener for opioid use disorder, also had much greater sensitivity to pain, whether they were on opioids, whether they were on low-dose opioids or high-dose opioids. So it kind of gets back to that genetic idea. Are there patients who are at greater risk for addiction who also are more likely to feel pain more intensely and have that same pattern emerge, whether they're on low-dose or high-dose opioids? So, translating from the bench to the bedside, how do we treat opioid-induced hyperalgesia? As you saw, we know a lot about opioid-induced hyperalgesia in animals. We're still all in the field kind of wondering about how this fits in with the treatment of chronic pain. But based on what we've learned from the animals, these are kind of some of the ideas we have about providing treatment for opioid-induced hyperalgesia in patients. Opioid sparing is number one. We saw over and over again that the more opioid you exposed a patient to, or an animal to, the greater that their opioid-induced hyperalgesia was going to be. And we know that it's dose dependent and length of exposure. So the lower dose, the less potent, the less time patients on opioids, the less likely they are to develop opioid-induced hyperalgesia. We also know that if somebody's on opioids, a gradual taper, as opposed to that abrupt naloxone administration we were putting people into withdrawal, which made the pain worse. So patients who appear to have opioid-induced hyperalgesia, a slow taper off of their opioids would be the way to go. Putting them into withdrawal is only going to make the pain feel worse. I mentioned this a minute ago with respect to the opioid pharmacology. Those longer-acting agents are more likely to induce opioid-induced hyperalgesia. It looks at the exposure of it, as well as the potency or the intrinsic activity of the opioid itself. Is it a really potent opioid? And we know from the animal studies that makes a difference. We also, based on those molecular mechanisms of action that I showed you when we looked at the brain and the spinal cord and the immune cells, that there are certain medications that can work at those sites to help maybe mitigate the effects of opioid-induced hyperalgesia. So antagonists of those excitatory amino acid sites that I pointed out in the spinal cord, and these are names of a couple of those antagonists, may be able to block the development of opioid-induced hyperalgesia. There are also certain medications which, in the opposite of those excitatory amino acids, are actually neuromodulators which kind of quiet the nervous system down. They're GABA agonists, GABA agonists or GABAergic agents, and things like propofol and gabapentin are both medications that can kind of quiet the nervous system down, and so that those may be able to counteract the effects of opioid-induced hyperalgesia. And then, as we saw, with the immune cells being involved, there appears to be a pro-inflammatory hypothesis or mechanism underlying the development of opioid-induced hyperalgesia. So by simply giving some of the over-the-counter anti-inflammatories that we give, might those be able to help manage or at least mitigate the effects of opioids on pain systems? So translating from the bench to the bedside, we still have a lot of questions in humans, but there are some things that we've learned in animals that we can take with us to think about managing opioid-induced hyperalgesia in patients. Okay, now so moving from that bench to bedside, I'm now going to move a little bit from the bedside, what we know about treating patients' pain, to the community. And many of you are probably familiar with the fact that the CDC came out last year with some important guidelines for prescribing opioids for chronic pain. And one of the things stimulating this work was the fact that we see such a large opioid epidemic currently occurring in our country. And to get these guidelines, they basically did a good review of the literature, they graded the evidence, they brought in experts to give their opinion, they brought in other federal partners, so not just the CDC, but WHO and SAMHSA and other sorts of organizations. The evidence was reviewed by peers, and they brought in also constituents, patients who had chronic pain and patients who were on opioids to really talk about these guidelines. And I'm going to not focus on all of the guidelines because they have recommendations on when to initiate and continue opioids for chronic pain, recommendations on opioid selection, but I'm going to focus on the guidelines that had to do for assessing risk and addressing the harms of opioid use, because one of those harms, one of those risks, is the development of opioid use disorder or addiction. So I'm going to focus on those guidelines. And the key question in these guidelines asking about that, these were kind of the key questions trying to figure out the risk of providing opioids to chronic pain patients with respect to opioid overdose, addiction, abuse, or misuse. There were 4 of them. What are the accuracy of instruments that we have out there for predicting the risk of opioid overdose, addiction, abuse, or misuse in patients with chronic pain? What are the effectiveness of risk mitigation strategies? And I'll go through a couple of those in a minute, but what are things prescribers can do to minimize the risk of patients running into trouble with their opioids? How effective are these risk management strategies? And what is the comparative effectiveness of different treatment strategies for managing patients with addiction? So these were kind of the key questions the CDC put out there, looking for evidence to support how do we manage and how appropriately manage patients with chronic pain with opioids. Those risk mitigation strategies I spoke of just a moment ago, these are some of the key strategies that have been identified in the literature. First of all, using risk prediction instruments. So like that SOAP I showed you a few minutes ago, which was kind of a screening tool for addiction in patients with chronic pain. So the importance of using some of those tools to look for the risk of predicting the risk. Using an opioid management or treatment agreement or treatment contract such that the clinician and the patient kind of go through what are the rules of me giving you opioids, what do you need to do, what do you need to watch out for. And not so much as this is a contract, and if the patient breaks it, you can take it to court or something like that, but it's really good educational experience for the clinician to sit with the patient and say, this is what you can and can't do, this is what you should and shouldn't do with these opioids that I'm providing you. Patient education is a big part of that. Urine toxicology, taking random urines from patients on chronic opioids to see, number one, are they taking their opioid? And if it's not there, they could be diverting it. And number 2, are there any other illicit drugs showing up in their urine which makes you think that they may have some sort of substance use disorder? So the importance of doing urine toxicology. Also the use of what are known as prescription drug monitoring programs. And almost every state in the country now has a prescription drug monitoring program which a clinician can call into and see where that patient has obtained opioids recently. Are they going to the dentist? Are they going to the ER? Are they going to other clinicians? So that the clinician can get a sense of whether or not this patient seems to be opioid seeking and therefore may have an underlying substance use disorder. In addition to tools to screen, there are also tools out there to monitor patients who are taking opioids for their use for their chronic pain. Are they engaging in behaviors that make you concerned that they may be abusing their medication? So there are tools to use that. Pill counts, having the patient bring in their bottle of pills and counting to see are they, taking more than they should be. And then the use of certain types of medications that they're compounded with certain other, they're formulated so that they can't be abused. So it's formulations that are difficult to maybe crush and put into your vein, formulations that may have an antagonist compounded with it. That's another way that we can mitigate risk. And this is just quickly going through some of those screening tools I mentioned. There's the SOAP, the ORT, the BRI. These are just some of the risk assessment tools that are out there. And what this review of the literature found is that basically there's not great evidence for either of these tools, that the strength of the evidence, I think it's on the next slide, there so you can see it better, is insufficient, low, insufficient, insufficient, insufficient. So for each of those 4 key questions that we had out there at the very beginning with the CDC guidelines, there's really no evidence to provide rationale that these will really work. There's no data out there to support it. So I bring this up to show how we've taken some things, some important ideas that we take from the patient to the community, to the CDC guidelines that really are not evidence-based. So again, there's a problem there with the translation. So when we talk about translating from the patient to the community, even the CDC is, there's limitations in how that's being translated. So I won't go through these, we're almost out of time, but basically the body of evidence is insufficient for the effectiveness of risk assessment tools and mitigation strategies in reducing harm. The comparative effectiveness, again, there's no comparative data available, so the CDC guidelines are based on that. These are some of those monitoring tools. Again, won't go through those in great detail, but there are monitoring tools out there. Here's some more of those monitoring tools. One thing to keep in mind is those monitoring tools are basically measuring aberrant behaviors, not necessarily measuring the true substance use disorder, but that those tools, there's no evidence to show that they work. Based on the recommendations that we do have evidence for in these CDC guidelines, they do recommend using those prescription monitoring programs at the state level 1 to 3 times a month, doing urine drug testing at the initiation of opioid therapy and at least annually. Avoid prescribing opioid analgesics to those on benzodiazepines. The great majority of patients who die from an opioid overdose either also have alcohol or a benzodiazepine on board, so that you don't want to co-prescribe these. And if an opioid use disorder is present, refer to or arrange evidence-based treatment, perhaps including medication-assisted therapy. And these are just some risk factors for opioid-related harms, and these have to do with patients who don't necessarily have a substance use disorder. Opioid overdose is a respiratory depression. People stop breathing, so anyone who has any sort of respiratory issues, sleep disorder, breathing, sleep apnea, pregnant women shouldn't have them. People who can't metabolize opioids well shouldn't have them. Older people, patients with other mental health conditions, of course, substance use disorder or previous opioid overdose are all at risk for opioid-related harm having to do with overdose. And then the ability to, and we do this a lot in the community now, offer that Narcan, that opiate antagonist, if anyone is at risk for these different sorts of outcomes. So from the bench to the bedside, how does this work for looking at chronic diseases? And this are the chronic diseases of interest today in our lecture. There are certain non-modifiable risk factors, and those are pretty easy to pick up in the animals. But some of the other factors that relate to addiction and chronic pain, behavioral risk factors and cultural and environmental conditions, those are very difficult to measure in an animal, right? So some of the key factors that relate to the development of chronic illnesses are not things that are easily measurable or at least easily identifiable in animal models. That really it's only those non-modifiable risk factors that we can see, genetics and certain responses to medications. We know that chronic pain feels different from acute pain, and here's a healthy brain that when you have a little bit of pain, you can see the parts of the brain that light up. When you have chronic pain, you can see that there's much more involvement of thoughts and emotions. How do we translate that to the animal? Acute pain we can kind of translate to the animal. A lot of it's related to the tissue, but when you get into a chronic pain situation, a lot of what the chronic pain patient is experiencing have to do with their thoughts and their emotions around the chronic pain. Can we ever really model that in an animal? And this is just looking at some of the things we know treats chronic pain. And again, many of the things you see on this slide are related to treating the thoughts and the emotions that go along with chronic pain. So we really don't know how to best treat chronic pain based on our animal models. These quickly are the indicators of a substance use disorder. I won't go through these in great detail. These are those DSM-5 criteria. But again, these are primarily behavioral in nature. Being behavioral in nature, how do we measure these in animals? Addiction's a chronic disease, has a pathological basis, known risk factors, a predictable course, just like diabetes, pathological basis, we know where the disorder lies. Known risk factors, we know those for diabetes, same for addiction. That's a predictable course. If you don't treat diabetes, patients die. If you don't treat addiction, patients die. There's a predictable course with it. But the treatments of known efficacy require behavioral sorts of changes, and it's most successful when treatment is ongoing. Again, how do we bring in things like motivational interviewing or cognitive behavioral therapy for an animal. It's difficult to extrapolate from the animal model into chronic diseases. And most of the interventions that we know work for chronic diseases, whether it's addiction or diabetes or obesity or chronic pain, again, are things that are difficult to measure, are difficult to simulate, are difficult to duplicate in an animal model. Motivational interviewing, cognitive behavioral therapy, acceptance therapy, accepting the fact you've got a chronic illness, doing a good psychiatric assessment, helping them manage stress, a functional assessment, how well can they get out of bed and take care of their kids and go to work. These are all difficult to model these are all difficult to replicate in an animal model, and yet we know these are the interventions that really work for a chronic illness. So in looking for treatment for things like a chronic illness like addiction or chronic pain, how much can we actually learn from animals beyond those modifiable risk factors?